Good afternoon, everybody, and thank you for waiting. Welcome to the Helping Smokers Quit web conference call. At this point, Dr. Sarna will be discussing the topic further. Dr. Sarna, at this point, the floor is yours.
Thank you very much. Welcome, everyone, to a presentation of Helping Smokers Quit, a national program just for nurses in West Virginia, Indiana, and California, funded by the Centers for Disease Control and Prevention. I am Linda Sarna. I'm going to start off the program today telling you a little bit more about what this is about. Then Dr. Stella Bielas from San Francisco is going to tell you about some of the health effects of smoking. And I'm going to come back and tell you more about how to help patients quit smoking using our current evidence. This is a photo of Dr. Marjorie Wells, who is our project director, and you may correspond with her in case you have any questions. The program today will last about 40 to 50 minutes. Please do not feel that you need to take notes during the presentation, as the PowerPoint of this talk is available for download on the Helping Smokers Quit page. I hope all of you have received your toolkit of materials specially developed for nurses in West Virginia, and we'll be talking to you more about how to access that Helping Smokers Quit page. Do, however, feel free to write down any questions that you may have, as we will have a question and answer period at the end of this presentation. Now, this training program today is only part of our overall project, which is to provide nurses with the knowledge and skills to deliver evidence-based smoking cessation interventions to patients who smoke. Most of us did not receive this content in schools of nursing, and we may have many myths and misperceptions about the most effective ways to help people quit. We also want to disseminate resources via our website, tobaccofreenurses.org, and especially via the Helping Smokers Quit page, which has been developed just for this project. Now I'm going to pass the baton to Stella, who is going to tell you a little bit more about how we got involved in this and how important nurses are in helping smokers quit. Stella?
Hi, everybody. Thanks for joining us today. The end of the project, or the end goal of this project, is actually to continue to change what it is that a good nurse does. It used to be in the past, and it's still in some settings, such as psych settings, that part of being a good nurse was to actually helping your patients smoke. As this photo from a magazine post-World War II shows, the nursing lighting up the cigarette for a patient. Of course, these days, we think this is impossible. Nurses will never do that. However, nurses may not be doing as much on the other end to help patients quit as they could or should. So our project is really to start changing the definition of good nursing practice. This definition and this change is being helped by the Joint Commission decision that accredited hospitals are required to provide smoking cessation interventions for patients with a diagnosis of heart attack, heart failure, and pneumonia. And a lot of times, in a lot of the hospitals who are in compliance with the Joint Commission requirement, the nurses are the ones who are working in to provide the cessation intervention. So the better prepared nurses are to change good nursing practice and science-based nursing practice. This slide is just a reminder that smoking remains the leading cause of preventable death in the United States. It's a very serious cause of death. It is preventable. We know what to do. We know what works. So we need to put more effort into making things work. And although most people know about smoking and lung cancer, it's important to remember that actually the leading cause of preventable death due to smoking is cardiovascular diseases. We see a lot of news about hypertension, about cardiovascular diseases being a big killer in the country or in the state. And we have to remember that about a little over 30% of deaths due to cardiovascular diseases are preventable because they are attributable to smoking. In West Virginia alone, almost 4,000 deaths a year are caused by smoking. So it's a significant number of deaths that could be preventable. These are some of the good news. The trends in adult smoking in the United States are been going down. Now we have about 1 in every 5 adults are current smoker. The number is slightly lower for women. However, which is a little bit of a concern, is that the line is not going down as sharply as we would like it to see. It's starting to reach a plateau, and that's where we really need to double our efforts to help adults quit. It is important to remember that about 70% of people who use tobacco do want to quit. So sometimes nurses feel a little bad to bring up the issue of tobacco or quitting with their patients. They don't want to bring stress. They don't want the patients to get upset with them. Maybe this is not the good time to talk about quitting. But we have to keep in mind that 7 out of 10 times the patient actually want to quit and will welcome your intervention. It's also important to remember that even people who do not want to quit or may not think they're ready to quit, they expect health professionals to talk to them about their smoking. This is the smoking prevalence in West Virginia. Unfortunately, the news are not as good as in the rest of the country, and the bigger concern is that we see there was actually an increase in smoking among men in West Virginia, and the decrease among women is very flat. It's almost flat. So higher rate of smoking than in the rest of the country, in most of the rest of the country. A little over 1 in 4 adults smoke, and male and females, a higher rate of female smoking. So these are very important things to remember when we try to tackle the challenges. I'm going to go over some of the facts about tobacco use in West Virginia. As Linda said, these are available to you on the website, and these numbers, the factoids, are also available to you on the toolkit you received and on the website for download. But these are some issues that we need to pay attention and be of concern for nurses. A very high incidence of smoking during pregnancy. Pregnancy is a good opportunity to try to help women quit because they have concerns about their unborn child. And again, over 1 in 4 pregnant women still smoking. Smoking among young people, young adults, very high, almost 35%. This is a concern because a lot of the focus sometimes is on helping older people quit. And in fact, we also can help the young adult quit. So we have to keep in mind that quitting is always a good thing to mention to all of our patients, not just focus on patients who already have emphysema, already have a cardiovascular disease, important to those as well, but we may encounter sometimes younger people who are smoking, and we may hesitate to bring tobacco use to them, but we should. Adolescent smoking, very high levels in West Virginia. It's important because the adolescent smoking and young adult smoking, it's what lead to that plateau or to the increase in smoking prevalence among adults overall. West Virginia has a unique feature about the level of use of smokeless tobacco use or chew tobacco. And it's about the second in the United States. These numbers vary a little, but overall a high level, mostly men. And a lot of times we forget to mention to our patients, we ask about smoking, but we forgot to ask about other forms of tobacco use. In West Virginia, that is definitely a very important thing to add. And this is another very important factor that we forget. Tobacco-related healthcare costs, not only tobacco causes a lot of damage to the individual and to their families, it's actually costing taxpayers over almost $700 million every year to treat tobacco-related diseases of West Virginians. Smoke-free workplace laws help people quit, help people decrease their consumption of cigarettes. We still don't have a statewide legislation in West Virginia that protect all workers from secondhand smoke, but there is some progress in that way. A lot of local legislation already protecting workers from secondhand smoke, and hopefully the goal will be to become statewide legislation. Cigarette taxes in West Virginia are still low, about 55 cents a pack. And why are cigarette taxes important? Why am I talking about it? Particularly for adolescents and young adults that we mentioned where have high levels of prevalence, the higher the cigarette taxes, the higher the cost of cigarettes, the less likely they will smoke. It's actually a smoking prevention strategy to make cigarettes more expensive. So the more expensive they are, the least amount, because young people tend to have less disposable income. Of course, this has happened under the pressure from a formidable opponent, the tobacco industry, spending over $130 million a year in West Virginia alone to market tobacco products. So we have to keep that in mind, that there is an environment, there is a powerful force out there, the tobacco industry, that is trying to promote tobacco use. This is to remind us that there are many compounds in tobacco that are harmful to the organism. Most of them are carcinogens. A lot of these products or components of tobacco, cigarette smoking, may not be harmful in its natural state, but under combustion with the heat of the cigarette, they may become harmful, and also in combination. But in the tobacco smoke, there's gases that are harmful, such as benzene, for example, and we'll think about inhaling benzene or ammonia. And there's particles. Nitrosamines, for example, is one that is very much mentioned. And of course, polonium, which is radioactive. It's important to remember that nicotine is not what causes most of the tobacco-related diseases. Nicotine is what creates addiction to tobacco products. In 2004, the Office of the Surgeon General issue an update on the health consequences of smoking. The Surgeon General has issued these reports for over 40 years now, and every year, every time each report updates and there's new evidence. And these are some of the major findings of the report, that smoking harms nearly every organ of the body. So there's very few organs that do not get affected by smoking. So for those of us working in med-surg floors, the likelihood that we'll find a patient who is hospitalized due to a tobacco-related disease, it's very big. It's a big probability that we will encounter patients with tobacco-related diseases. Quitting smoking has immediate and long-term effects, and it's always a benefit. It's always a good time to quit. Another important finding is that lower machine measure yields, and machine measure yields are the machines that are used to call cigarettes, for example, lights, ultra lights, mild, extra mild, super lights, things like that. And these are definitions created through a machine. They do not reflect how people actually smoke, and they do not reflect the amount of components of tobacco, nicotine, and tar, for example, that humans get into their body when they smoke. So the Surgeon General said without doubt that switching from regular to lights, for example, it's absolute not a choice that promotes health. And the list of diseases caused by tobacco keep expanding. This is a list that came on the 2004 Surgeon General report. And like I said, most of us know about lung cancer. Almost all of us know about coronary heart disease and things like that. A few of us, for example, realize that bladder and kidney cancer are caused by tobacco, or acute myeloid leukemia, or reduced fertility in women. We see a lot of that happening in the country with women who are trying to get pregnant. And sometimes we forgot to find out if they're smokers. Cataract, osteoporosis. Like I said, the chances that we encounter patients that do have a tobacco-related disease, it's very, very large. These are to remind us that, particularly in West Virginia, although cigarettes are the most common form of tobacco use in the United States, there is also a significant portion of the population who uses smokeless tobacco, and most males more than females, and the prevalence is highest among youth, American Indians, and rural areas. And it's important to know because they keep growing, the types and forms of smokeless tobacco that exist. And one of the latest developments that is being tested by the tobacco companies in several states is they call snus, which is the tobacco that come in those little tea bag type things that you put on your upper lip. So as opposed to spitting the tobacco on a cup, you actually spit the little tea bag, and that has been marketed heavily to people, particularly for areas that go in smoke-free, so people can use that type of tobacco instead of smoking. So it's promoting dual use of smoking and smokeless. And I'm bringing that up because although we discuss the series of diseases caused by smoking, smokeless is not without harm. So it's not a harmless option to switch to smokeless tobacco if you're a smoker. It causes a series of oral diseases. It causes oral cancer, oral pharyngeal cancer, and there's recent studies showing about the impact of smokeless tobacco on the cardiovascular system. There's new research about that. So again, it's not a harmless option. Secondhand smoke, like I said, particularly in states where there's no statewide protection against smokers, a very important cause of tobacco-related disease. The Surgeon General, again, in 2006, issued a report, an update about all the harms caused. And a couple of things are very important. One is that there's no safe level of exposure. So, for example, restaurants that have smoking and non-smoking areas, and they're pretty much side by side, that do not provide any protection to workers against the toxic exposure to secondhand smoke. And we sort of knew about, most people know about how bad it is for children to be around smokers. Several serious diseases, sudden infant death syndrome, and one of the most serious, of course, but respiratory infections, middle ear infections, asthma, severity of asthma. However, there's also immediate cardiovascular system, negative impact on the cardiovascular system. Risk of coronary disease and lung cancer is also increased by those exposed to secondhand smoke. So another consequence of smoking. Another consequence of tobacco use that you may want to bring up with your patients, not related to health, but in particular in tough times might be worth mentioning, is the economic cost of smoking to the individual. We already talked about the cost of smoking to the state and taxpayers, but there's also cost to individuals. This chart tried to show you how much money one would have saved over a lifetime of smoking if that money has been used, put it into a savings account. You also can go over with your patient about what if every day for a month, instead of buying cigarette or buying a tin of smokeless, they put the money into a jar, and at the end of the month they can treat themselves, or they can go with the family for pizza, or they can buy a digital camera, or whatever it is that they want to buy. That is a very, very concrete reward for quitting smoking, because a lot of times patients may not realize, particularly younger patients, that the benefits of quitting are so immediate. But these are a very immediate financial benefit from quitting. Again, like I said before, smoking at any time is always beneficial. Smokers, in average, lose about 10 years of life. And this is a study that followed about 35,000 male British doctors throughout 50 years. And what they found that even the people that quit in their 60s did gain years of life. So smoking at any age, it's a good thing to do. You're never too old to quit. You're never too young to quit. So you got to remind your patients. We hear about like, oh, it's too late for me now. I've been smoking for 40 years. It is never too late to quit. This is to remind you of the benefits. Like I said, there's immediate and long-term benefits. So some of the immediate benefits smokers get from quitting is that circulation improves and lung function improves within 2 weeks of quitting, and it continues towards up to 3 months to improve. We also see that then the risk of cardiovascular disease, you start to decrease right after a year until eventually it reaches the level of somebody who has never smoked. Another benefit of quitting is that the regaining of function of the lung cilia. That means lung cilia gain motility and helps because it's been paralyzed by tobacco use. And once you stop tobacco use, you gain motility. That, in some patients, without any other underlying diagnosis, it may lead to a cough. And that cough basically is the cilia moving again to read the body of all the particles that have accumulated through smoking. So if you hear your patient complaining about, oh, I quit and I'm coughing, so I'm getting more sick after I quit, please investigate if there's no underlying diagnosis. It could be a cough created by the regaining motility of the lung cilia. Again, tobacco dependence is actually a two-part problem. There is a very proven scientific physiological component, which is the addiction to nicotine. And as we're going to talk a little bit more about that, it does change the chemicals and the neurochemical functions of the brain. And for that, there's medication that helps with cessation. However, there's also a very important behavior component to nicotine, to tobacco dependence. And that's, for example, the patient who says, oh, but I can give up the cigarette after coffee or after dinner when I watch TV, and I always smoke when I'm driving to work, and these are things that I have a very hard time giving up. So again, that's a behavioral component that you have to work with the patients. It's important to remember that because it's a two-part problem, the most effective treatment is the one that do address both the physiological and the behavioral aspects of dependence. cigarettes are the most effective nicotine delivery devices ever invented. It takes about 11 seconds after a puff for nicotine to reach the brain. It only takes about 3 minutes for an arterial concentration peak of nicotine in the plasma and a little lower venous, and then it slowly goes down, and that's when tobacco users will self-titrate to, again, take another puff and get another peak. But again, 11 seconds, it's important to remember that, because when people are trying to quit, they may not get that quick response that they get with the cigarette puff. And this is pretty much how it works. You take a puff. Within 11 seconds, nicotine stimulates dopamine release. That creates a pleasurable feeling, which leads, again, as the serum plasma concentration decreases, to repeat administration. And tolerance does develop. Most people don't start off as a pack-a-day users or two tins a day or a tin a day. They build up to their level to reach the optimum level of nicotine concentration, where they can maintain the optimal level. It's important to remember nicotine is an addiction. It's not just a bad habit. It's not that all it takes is willpower to give up. It doesn't mean if somebody relapses or somebody can quit. It has nothing to do with being weak or not being strong enough to quit. Tobacco users, because it is an addiction, tobacco users behave as any other addicted person. They do anything they can to maintain a minimum self-nicotine concentration, which will prevent withdrawal and maintain arousal, maintain mood, modulate mood. And they also will self-titrate. Either they're going to smoke or dip more frequently to make sure they maintain that minimum serum level. Ideally, they can smoke more intensely by taking deeper puffs, for example. Or if they're trying to switch to light cigarettes, they're going to block little holes that these cigarettes have that leads to a lower machine measure of tar nicotine. And in fact, by blocking that, they'll get a higher level of nicotine in their body. These are some of the well-documented withdrawal effects of nicotine. It's important to remember that when our patients are in the hospital, they are under a forced smoking cessation period because our hospitals are smoke-free. So a lot of times we notice that they're having depression or anxiety or irritability, and we're not sure, and we're thinking, what does have to do with their diagnosis? Or maybe they're just upset for being hospitalized. And in fact, if they're smokers, they may be suffering from nicotine withdrawal. Most withdrawal symptoms subside within 2 to 4 weeks. However, there are medications that help patients deal with that withdrawal symptoms, and that's a very important thing to remember. So there's effective medications, and these medications, when used, help with the withdrawal symptoms and help the patients achieve long-term quitting. And Linda's going to discuss more about the details of these medications with you. Linda?
Thank you, Stella. Well, Stella provided us with a comprehensive foundation for understanding the devastating health effects of tobacco use and also some of the benefits for quitting. But what I want to focus on and what's really important as part of this project is how we can help smokers to quit. And one of the things that we know is that in 2008, we have more resources available than ever before, and we have a number of FDA-approved medications that are available to help with those troubling withdrawal symptoms that Stella described. In your toolkit, there is a pocket guide called Helping Smokers Quit, and as part of that pocket guide is a fold-out description of each of the medications on this slide and a little bit about the side effects, dosage, duration, and availability. And I'm only going to briefly review them today, but there is more information available elsewhere. Well, first, let's talk about nicotine gum. Nicotine gum has been around since the 1980s. It was the first nicotine replacement medication, and you'll notice that a number of these all have nicotine in front, and that means that they replace the nicotine. The other two are a little bit different, so we'll talk about those in a moment. Anyway, nicotine gum is really not a gum, but it's a product, and people, depending upon the number of cigarettes that they smoke per day, they may take a higher or lower dose. For example, if they smoke over 25 cigarettes per day, they would take the 4 milligram product and use up to 24 pieces a day. This product can be used for up to 3 months. It's over the counter. Basically, people chew the product and they park it between their gum and buccal mucosa so that the nicotine is absorbed. The second product that we want to describe is the nicotine lozenge. This is one of the newer products. This is depending upon when a smoker has their first cigarette. For example, if they need their first cigarette before 30 minutes upon awakening, they would take the higher dose, the 4 milligram dose, and use up to 20 pieces a day. This is also used for about 3 months and is over the counter. There is some local irritation, some nausea, but generally a number of patients like this as an option. The next is the transdermal nicotine patch. This came on board in the 1990s. This is delivered in a step-down method with more higher doses initially and then step down over time. It's used for approximately 2 months, and it is also over the counter, although some can also receive prescription and reimbursement from certain insurance agencies. This particular patch may cause some local skin irritation and perhaps some insomnia, so that some patients need to take the patch off at night and then put it on in the morning. The next is the nicotine nasal spray. The nicotine nasal spray gets the nicotine to the brain quicker than some of the other nicotine replacement products. It is prescription only and can cause some nasal irritation and can be used for 3 to 6 months. And the nicotine inhaler, also a newer product. Patients use 6 to 16 cartridges a day. They do inhaled medication similar to a cigarette, and it's used for up to 6 months, and it also is only by prescription. So all of these products that I've described thus far are nicotine replacement medications. That means that people cannot smoke and use nicotine replacement at the same time, because if they do, they will have increased nicotine toxicity, their heart will race, their blood pressure will rise. So these products are only to be used if the people are going to make a quit attempt and put away the cigarettes. Now, the next products are not nicotine replacement. They work as agonists to sort of prevent that pleasurable feeling of smoking. People don't smoke because they feel bad. They smoke because it feels good. Now, with both bupropion and varenicline or Chantix, patients start taking medication before they make a quit attempt in order to get an adequate blood level. Both of these medications are prescription only and require supervision of a healthcare provider. You probably have heard some of the side effects that have gotten some media play. There are certainly people who have a history of seizure disorder or eating disorder it's contraindication for taking bupropion, and varenicline has been associated with changes in mood, and people who do quit smoking do have changes in mood, and they need to be monitored, especially if they have some severe problems. Both of these medications can be used to up to 6 months. So the nice thing is that there are lots of different choices that you can give patients describing all of these different medications so that they can select the one that's best for them. Most patients who quit have already have tried to quit before, and they may be familiar with some of the medications, and perhaps they had some side effects. So you can help support them through that. Again, nicotine replacement reduces the physical withdrawal from nicotine. It eliminates that immediate reinforcing effect of the drug that's so rapidly absorbed via tobacco smoke, and it allows patients to focus on the behavioral and psychological aspects of quitting. Just slapping on a patch or just using the nicotine gum alone is not as effective as both receiving social support, getting the skills set about the most effective ways to quit smoking, and addressing nicotine withdrawal. Now, this slide looks again at the different nicotine-containing products. As Stella mentioned, using the cigarette, using snuff are certainly more effective in terms of getting nicotine more quickly into the blood system. And the other medications do provide some sustained nicotine delivery, but they don't get quite that high. Again, here's the nasal spray, as I mentioned, getting it a little bit faster into the bloodstream. Now, the issue with tobacco cessation, and the reason that we're really taking the time to address this project, the importance of social support, is only 5%. 5 out of 100 people who quit without any assistance are able to be smoke-free 1 year later. Only 5. So that means that few people adequately prepare and plan for the quit attempt. Many patients don't understand the need to change their behavior. They can't just make themselves quit. They really need to address the withdrawal symptoms and also get the support that they need. That's why behavioral counseling is such an important component of quitting tobacco use. The good news is that clinicians can make a difference. No clinician at all, self-help material, a little bit of a benefit. We know how we like to hand out those self-help materials. Non-physician clinician, that's nurses, respiratory therapists. We can also increase quit attempts, and here are physician clinicians. So we know, and also the science demonstrates that the more people involved, the better. But we can almost double the opportunity for a long-term quit attempt by providing advice and counseling. Now, the research about the efficacy of nurses is growing. So compared to smokers who receive usual care as compared to smokers who receive some assistance from a nurse in quitting, they have a 28% greater probability of being quit for many months later. And we believe that this is going to increase as more and more nursing research studies are published. Again, this is a picture of the Helping Smokers Quit Pocket Guide. It's organized according to the 5 A's. The 5 A's are an organizing way to use the evidence for smoking cessation. Asking patients about tobacco use, advising them to quit, assessing their interest in quitting, assisting them with quitting, and arranging for follow-up. And we're going to briefly go over all of these. Stella and I are very proud about this booklet. We worked with the Agency for Healthcare Research and Quality to develop the first booklet, which was called Helping Smokers Quit, A Guide for Nurses. It was so successful that now it's been republished when the new 2008 Public Health Service guideline came out. So it's called Helping Smokers Quit, A Guide for Clinicians. So first, ask. Generally, healthcare professionals do pretty good about asking. We want to ask whether or not people use tobacco or whether other people in their household smoke. Patients expect us to ask about tobacco use. Again, tobacco use has the potential to interact with many medications, and it may be directly related to the condition for which they're hospitalized or what brought them to their primary care provider. So we want to ask, and we want to document it on the chart. The next is we want to advise patients to quit. Quitting is important. It's the most important thing you can do for your health, and I can help, or I can refer you to people who can help you. Letting people know that there are medications that are now available, that they have options, and you'll be happy to discuss them with you, or refer them to the physician, nurse, or pharmacist who are familiar with these products. and that you can provide them with resources to allow them to have the assistance for quitting. The next is assess. It is important to assess if smokers are interested in quitting. Most of them, of course, if they've entered a smoke-free hospital, are already quit for the duration of their hospitalization, and you may want to assess what their feelings are about maintaining that smoke-free status when they go home. But just because, even if they are not interested in quitting, we can still provide resources and assistance. I want you to remember that 70% of all smokers do want to quit, 70%. And if patients are not interested in quitting right then, you might want to explore with them about what their thoughts are about quitting, what the benefits that they view in terms of their quitting. And now that you know a little bit more about the health impacts, you can help them connect what the health benefits might be directly to their physical situation. You might discuss with them what the worst thing is that they're concerned about if they quit. And again, most patients who are smokers have tried to quit before. It takes 3 to 5 times of quitting before people are able to be successful, and they'll probably have some experiences that they want to share with you. Assisting patients to quit means setting a quit date. In the ideal situation, this would be 2 weeks after they've made the decision. They want to get the support from family and friends. Again, this is an opportunity to review what their past quit experiences were like, what helped, what led to relapse, to anticipate some of the challenges that they might experience, and very importantly, to personalize their reasons for quitting and the benefits thereof. So give some of the advice about successful quitting is complete abstinence is necessary, not even a single puff. And the reason not even a single puff is that research has demonstrated that smoking just one cigarette will lead to relapse. Drinking alcohol strongly associated with relapse, so you may want to discuss what their plans are during this quitting period. And having other smokers in the household also makes it more challenging. This may be an opportunity for the entire family to quit, or you may want to discuss how they're going to get support from their family members while they're trying to quit. This is also a chance to encourage the use of pharmacotherapy if it's not contraindicated. And again, lots of FDA-approved medications. Fortunately now in the United States, there are toll-free quit line numbers. The national quit line number is 1-800-QUIT-NOW. But in your toolkit, you have a card that's just for smokers in West Virginia, also for tobacco users, spit tobacco users too, which is 1-877-966-8784, and we'll discuss that in a moment. There are also website materials that are freely available, and again, our Tobacco-Free Nurses website has materials just for nurses, appropriate for different types of smokers who are trying to quit. A critical aspect of smoking, for smoking cessation, perhaps the most critical aspect, is follow-up. Follow-up is important because many people will tell you they've tried to quit, but it is the relapse that happens often within the first week of making the quit attempt, where we need to reach out to people to provide the support and the encouragement that they need. Relapse is not a failure of the healthcare provider. It's not a failure of the patient. It's part of the quitting process. It's an opportunity to review circumstances that caused the relapse, to use it as part of a learning experience, to reassess to pharmacotherapy, and to lead to those other resources. Well, one of the things we want you to know about is that another strategy for helping people quit is to refer them directly to the quit line. You may have a hospital-based cessation service program, but few hospitals have that. You might have some local groups, the American Cancer Society, American Lung Association, do have those, and they can provide some of the support. And you might have, if they're taking certain medication, there are also some support packages, quit line numbers, internet counseling that may be appropriate. There are internet programs. QuitNet.com is one of the better ones associated with evidence-based, but the quit line is another strategy. So I want to take a few moments to talk about the quit line. The quit line in West Virginia is free. It's simple and it's easy to integrate into your routine patient care. It is effective. It definitely increases long-term quit attempts, and it's provided at no cost. Smokers who call the quit line receive one-on-one counseling and follow-up. They receive free materials that are tailored specifically to their needs, and in West Virginia, they can even get free medications to support their quit attempts. Now, the good news is to let patients know that it's available from 8 a.m. to 9 p.m. Monday through Friday and 8 to 5 Saturday through Sunday. You can also get additional materials from their website, also from the West Virginia Division of Tobacco Control. Now, for this project, we want to make sure that you go to the Helping Smokers Quit website. This is only for nurses who are involved in this program, so you have to access it by typing in the username HSQ and the password HSQ as well. So why should nurses in West Virginia address tobacco? Well, we hope that we have convinced you that it's one of the most important things you can do for your patient's health, and that each of the 30,000 nurses in West Virginia were to help just 4 smokers quit per year, you could reach 120,000 smokers, about a third of the smokers in your state. There are 3 million nurses in the United States, and we know that if each of them are equipped to help the approximate 45 million smokers in the U.S. to quit, we could make a big difference. Now, this is a picture of the Tobacco Free Nurses website, and this is where the Helping Smokers Quit tab is. I will tell you on the website there are lots of other materials about nurses and helping patients quit tobacco, lots of resources. You can also get the Helping Smokers Quit booklet printed out. Remember, you have to type in HSQ to enter the site. Once you enter the site, you will find special tabs just for nurses in California, Indiana, and West Virginia. Once you click on to that, you will get specific materials that are helpful for people in your state, some of the regional resources, some of the materials that are tailored for the experience of people in West Virginia quitting smoking. You also, on this tab, will get frequently asked questions, a listing of questions that we've received from nurses like you who are trying to help their patients quit. After we leave the program today, you may want to go and look at some of those questions, because I'm sure that in this brief educational program, we're not going to be able to address all of your concerns. This also has a link to the Treating Tobacco Use Dependence Clinical Practice Guideline 2008 update, so you can get more detailed information about the strategies that we've discussed. But now we'd like to take your questions. I would like to tell you, though, that this is not the end of our intervention. You have received the toolkit. The toolkit, again, provides a special page just a fact sheet for nurses in West Virginia. It also has a fact sheet about how nurses can help patients with smoking cessation, and it has the material about guiding you through the intervention and the pocket guide. We also are going to be working with your chief nursing officer to see whether there are any things that we can do to help nurses at your hospital facilitate smoking cessation interventions for patients. And in about 6 months, we're going to be asking the many nurses who completed our web survey some questions again about how they're doing. But Vinny, could you ask our listeners whether they have any questions, please?
Certainly. The floor is now open for questions. If you do have a question, please press the number 7 or letter Q on your telephone keypad. Questions will be taken in the order they were received. Again, if you do have a question, please press the number 7 or letter Q.
Well, if you don't have any questions, do know that we are there for you. You can contact us anytime directly through our website, or you can also call the number that's available to speak with our project director. Again, we have nurses in many hospitals in California, West Virginia, and Indiana who are engaging in this intervention right now. In a little while, we hope to have an audio tape and PowerPoint presentation up on the website so that some nurses who might have missed this training today can also log in. Stella, do you have any comments?
No, just to thank everybody for being with us today, and again encourage people to check our website. And also, as we start to implement these interventions that we discussed today, that's when the questions may come up. So both check the frequently asked questions or just send us an email and we'll get back to you. Thank you, everybody.
Okay, Vinny, no questions?
At this time, there's no questions.
All right, thanks a lot. Have a great day. Bye-bye.
Bye-bye.